patient history and examination is a really critical aspect, and I wanted to go into a little bit more depth so that we can make sure that we've got this foundation sorted. You know, it just can't be understated, and I wanted to go through, you know, exactly what that means. So let's go through, you know, quite a few different aspects. Definitely not exhaustive, but a really nice way to start. Initially, we should be establishing rapport, introducing yourself properly, explaining what you're going to be doing, why you find that important, and why that's going to give them a greater likelihood of a positive diagnosis and an appropriate management plan. Make the patient feel comfortable, secure, safe, you know, and that can come down to sort of your clinic, what's in your clinic, what's on the walls as well. So really making sure that everything comes together there. Now, active listening. Pay close attention to what the patient's saying, show empathy, understanding, and avoid interrupting unless necessary. Again, with the open-ended questions, that's going to help this even further and establish further rapport, because patients are going to be, you know, understanding that you're wanting more information out of them. But start with those open-ended questions like, can you describe your pain? Or when did you first notice these symptoms? You know, encourage them to speak freely about their symptoms and experience so that they can go into as much depth as possible. But when you start to exhaust that, we then need to be very specific. You know, start looking for those yes or no's with those specific questions to clarify any details that were maybe a little bit vague that we're talking about, so that you can get more comprehensive information about the patient's condition. Then you want to start reviewing the system. So ask about each body system, you know, whether that's musculoskeletal, neural, but also start getting a bit of an understanding of whether there's different things going on cardiovascular wise. How's their endocrine system? Really being in as much depth as possible is going to give you a greater understanding. I commonly prompt my patients to say, do you have any inflammatory conditions, such as rheumatoid arthritis, lupus, psoriatic arthritis? You know, these are the sort of things that I want to pull out because they potentially do have an impact on pain when we're looking at that. Now, that's going to very easily go into that medical history. You know, great, ask that open question, do you have any medical history, surgeries, allergies, medications? But then really, I do go into quite a lot of depth from a surgical point of view in, okay, do you have reflux? You know, do you have asthma? Things that are potentially going to become a risk, particularly if we're going under general anesthetic. In a biomechanical sense, it's, you know, yes, let's check allergies, let's check inflammatory conditions. Do they go to their GP? You know, it's great to say that I don't have any medical history, but when was the last time they touched base with a doctor? But also consider the patient's family history. As we all know, there's quite a genetic component to most concerns that we can see. Then start going into their lifestyle and social history. You know, don't just ask about their lifestyle habits such as diet, exercise, smoking and alcohol use. You know, start thinking about their social environment because they can really provide, you know, a real big impact on their health. And coming back to smoking, I'm very deliberately asking patients now whether they're also vaping as well, just to make sure that nothing is missed there. Now, at the end of each of these aspects and as you're going, you really want to summarize and clarify. It's that talk back method that, okay, am I hearing this right? Is this what's going on? And that really helps to really summarize those key points and make sure that the patient adds anything that needs clarifying or that potentially is more important to them. And I'll definitely say, okay, what I'm hearing today is that your heel pain on your left foot's quite bad, but actually your worst pain is on your lateral right foot. Is that correct? And that allows them to then go, yes, that is correct, and this is why. But then, you know, another really important aspect is discussing the goals. And I don't think there's anything better than creating a SMART goal. So specific, measurable, achievable, relevant, and time-bound. And definitely have a look at our other video with regards to SMART goals, because I think that's a really key aspect when it comes to looking after our patients. Now, once we've undertaken that systematic, really systematic subjective history, we then need to start looking at a systematic approach to how we're assessing patients, just so we don't miss anything. Now, we would all have our own approach to this, and maybe as new grads, we start to develop that, and in our years following, but particularly for those that have been out for several years, this is pretty well ingrained. And it often involves examining, maybe not only, but the foot, the ankle, but the lower limb as well. And that's a very specific approach that we develop ourselves, hopefully from some very good groundings at university, but we all do this differently. You know, initially start to observe your general observations of the patient. Look for signs of discomfort broadly, but also start thinking about skin color, you know, their posture and deformities, how they're standing, how they're moving, and other visible indicators that can give us, you know, an idea of what we're looking at and how we might be able to help. And then, you know, palpation, 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 a really critical aspect. Use your hands to feel the feet, the lower limbs, and for any deformity, but that's also going to provide us an indication of initial pain and other abnormalities, such as sensitivity or hypersensitivity. And this can help identify those areas of tenderness, structures of concern, and guide our diagnosis further. We'll then also be doing quite a few different special tests, and definitely not exhaustive, but it really depends on your patient's symptoms, you know, such as reflexes, nerve sensitivity with Tinel's, muscle strength, range of motion, and all of this comes in together. Now, my approach, I typically, as soon as I start talking to a patient, once they're in the clinical chair, I'll always double check that their arteries are, you know, palpable, because that's just sort of the way that I go. I'll then do a bit of a range of motion, some resisted strength, and then start looking at any palpable pain to specific structures. Now, for my approach, I definitely go over the full foot and ankle, and I'm really testing bones and then muscles, tendons, and I try to work myself from a distal to proximal area, but I also want to do the area of my perceived, the perceived area of pain last. And then I'll start doing my special tests like the dorsal draw, medial lateral squeeze, anterior draw, anything else there. Now, definitely, as we're going, you know, record your findings so that you're not forgetting, record them accurately and in depth, a really important aspect. I always take photos and videos of all of my patients as they're moving and you know, static as well, because I think that really allows for, you know, some reflection, some learning and some collaboration from our peers as required as well. One of the things that I'm more recently undertaking is the use of AI technology, in my case Heidi, but that allows me to actually verbally say my findings as I'm going through my consult, which is just fantastic because it means I'm not missing anything, and it's invaluable to make sure that my thoughts and findings are exactly as they are as I'm seeing and undertaking these assessments. Now, other things that you do want to be aware of are, you know, neurovascular assessments are really good. And don't just think, oh, they're for my patients with diabetes. They're for all patients. All patients have blood flow, all patients have nerves, and we definitely want to be making sure. I do, you know, a neurovascular patient on all of my patients over 30 that are going to surgery, but pretty much everyone that walks in the clinic is having a neurovascular assessment. Now, Tinel's percussion of nerve pathways is another great test. But another thing that people sometimes forget about is doing temporary taping or padding and then reassessing. So, you know, that might be with some medical tape like Hyperfix I use a lot, or even our semi-compressible felt. You know, start seeing how they're going to feel with a medial longitudinal arch, you know, or a D-pad in their inner soles for a medial longitudinal arch, and maybe put in a little bit of Hyperfix on their foot as well. And again, I just do a simple stirrup. It gives me a really good idea straight away of how that patient's going to respond. Now, you can do a Valix point assessment here. You know, this is a really good idea to sort of get an idea of, okay, where's their pain locally, but are there any other areas that are sensitive as we start going up that lower limb as well? And this can be indicative of, you know, that there's more of an entrapment and there's more of a neurological aspect that we're looking at than maybe we initially considered. Now, one of the things that I love too is that point of care ultrasound, POCUS. It really enables me to go, yep, great. You know, I believe the insertion of the perineal tendons where your pain's coming from, ultrasound's on. Within 2 minutes, I know exactly what's happening from when I first say to the patient, I'm just going to have a quick look, to it powering up, having a bit of a look, and, you know, identifying that concern. Straight away, I can go ahead with absolute certainty that it's, you know, going to be that patient is going to need a comprehensive management plan focused on the perineals. Now, again, we look at X-ray, fluoroscopy. I'm very fortunate to have fluoroscopy in rooms, but a weight-bearing X-ray is something that's not as easy to undertake on fluoroscopy. And so definitely, like us all, sending out for weight-bearing X-rays is another aspect that can be considered. Again, when we're not too sure, looking at an MRI or a CT, if we've done X-ray, ultrasound and still not finding what's going on, MRI is going to be much more effective at getting a greater appreciation of those soft tissues and bones, whereas the CT is going to be very, very specific on the bone side of things too. With or without contrast, of course. When we're looking at contrast and potential infection or inflammatory concerns, we are going to get a little bit of a greater understanding of what we're looking at. But hopefully this has given you a bit of an idea of how I undertake that patient history and examination process. Hopefully you've been given a few more tips just to slightly modify what you're probably already doing in clinic. Cheers.